on Fridays. I have no disclosures. I think it's important, for anybody who's interested in, starting a program or a center of CSF leaks, to find the right colleagues. And I've been really, really fortunate to work with a tremendous group of colleagues, not just in neurosurgery, but also in the other disciplines, and especially it's very neuroradiology heavy. And then, of course, headache medicine, that's usually neurologist, is very important, and anesthesia is very important. But I just want to point out a few people. So Rachel Taché is my nurse practitioner who really takes care of my whole practice. And then Dr. Maya and Dr. Moser, I've been working with since the year 2000 on these patients with CSF leaks. And actually, Marcel Maya, he is from Istanbul. I think he immigrated here in the 1980s. But it's really important to build that team. That's super important. So we're going to talk about spontaneous intracranial hypotension. And because that's kind of a mouthful, I abbreviate that to SIH. So we're going to call it SIH. But what's important to realize that even though it's called spontaneous, oftentimes it's not spontaneous, right? So oftentimes people get symptoms after some more or less trivial type of precipitating event. And we really keep calling it spontaneous to differentiate it from the other type of spinal fluid leak that we all see after spine surgery or after a spinal tap or a gunshot wound, perhaps. So that's what we mean by spontaneous. And it's not always hypotension. So in the beginning, we thought that everybody had low pressure of spinal fluid, either measured with lumbar puncture or with ICP monitoring. And by the way, I don't use ICP monitoring for this at all because I don't think it's that useful. Nowadays, we know that probably at least half of patients with active spinal fluid leaks have normal pressure when you do a spinal tap. Now, for a while, some people are still they call it the syndrome of CSF hypovolemia or craniospinal hypovolemia. But that's really a misnomer because hypovolemia, as we all know, that means low blood volume. And low blood volume has nothing to do with this. It's low spinal fluid volume. So probably a more appropriate term is CSF depletion syndrome. But that really is a little bit too complex, at least for me, to use in everyday practice. So we'll keep calling it SIH for now. Now, I became interested in this a long time ago, more than 30 years ago, when I was a resident at the Mayo Clinic in Jacksonville, Florida. And Neith Folger was the chairman of neurology there. And he had a patient who was an exotic dancer. She was 22. And there was a brawl where she worked. And she was hit against the side of her spine against the bar or a bar stool. And ever since that time, she'd been having these very orthostatic headaches. So headaches that were a lot worse being upright and were relieved in recumbency when she would lie down. And she had seen many doctors, nobody knew what was going on, but Neith Folger, Dr. Folger immediately diagnosed her with a spinal fluid leak. And we did a myelogram that you can see there, and we took her to the operating room. Nobody had ever seen that before. In the morning, we had clipped an aneurysm. So I said, well, to clip this leak, why don't we use an aneurysm clip? And that seemed to work really well. And I saw her about 5 years ago, about 25 years after her surgery, and she was still doing really, really well. So back then, so in the 90s, when this was diagnosed a little bit more frequently, everybody thought this was a really rare disease, right? So pretty much any patient who had this was either presented at a meeting or people would write it up in our literature. But nowadays, we know it's really not that rare. So about a year ago or so, we did a study on the incidence of SIH in Beverly Hills. Cedars-Sinai is very close to Beverly Hills, so we see a lot of patients from there. Obviously not everybody, and it's underdiagnosed, but In spite of that, we found an incidence of about 4 per 100,000 people per year. So that means it's about half as common as a aneurysmal subarachnoid hemorrhage, and it's at least as common as trigeminal neuralgia. So it's really not that rare of a disorder. And as you can see here in this figure, so every year since we started our CSF leak program in 2000, we've seen pretty much more and more patients each year. Last year we had a little bit of a dip in 2020 because of COVID, but we've caught up with that again. So it's really not that uncommon. And this slide is just to show that even though we see a lot of patients with this, so right now I think we're at about patient number 1,635, the reason we see so many people is because a lot of patients are referred to us. So only about 1 out of 4 people are from Los Angeles. Now, of course, you have to realize that Los Angeles County has about 10 million people, so it's about as big as Switzerland. So even though most patients come from far away, we also still see a lot of patients who come here acutely, either through our ER or through other ERs in Los Angeles. We know that it's really a disease that can affect anybody. The youngest patients we've treated was only 2. The oldest was 88. It's definitely more common in women, but it's really people in their 40s and 50s and 60s who are most commonly affected. And as you can see here, it seems that in the younger age group, so let's say before retirement age, before 65, it's more common in women. And in those over 65, it's more common in men. I don't know why that is, but that seems to be the case. Now, we used to think that SIH really would just cause a headache. And clearly, headache is the most important symptom still. But as you can see on this table on the left side, there's this wide variety of different clinical manifestations that these people can come see you, either in your neurosurgery or neurology office, or they're just coming through the ER, or they're transferred comatose from other hospitals. So I think you always have to think about it. But again, headache is the most common manifestation. And when we looked at 202 patients who I saw in 2020 with SIH, almost all of them had a history of a headache. They might not have had a headache when I saw them, but at the beginning of their disease, they had a headache. And almost always it was orthostatic, right? So orthostatic means it's better when you lie down and it's worse when you get up. And what I usually like asking my patients is, how did you feel this morning when you woke up, but you were still in bed? And then almost always they'll say, yeah, that's when I feel pretty good. The other type of headaches that you can get, right? So sometimes a patient has a totally non-positional headache. Sometimes people have a reverse orthostatic headache, so they feel worse when they lie down. Sometimes people just have a headache when they exercise. Sometimes they just have a headache when they perform a Valsalva maneuver. So it's just like a type of like a Chiari type of headache. Sometimes that positional component doesn't really show up after a few hours. And it's not that clearly orthostatic, but they'll tell you, I feel fine in the morning. And then in the afternoon, I start getting my headache. And then rarely people will just get trigeminal neuralgia, but that's pretty uncommon. So what are sort of the common associated symptoms? The most common are vestibular cochlear symptoms. So ear symptoms are really common: dizziness, ringing in the ears, muffled hearing, hyperacusis, so they hear everything really well, or that it will hurt their hearing. But more common is some degree of hearing loss. Nausea, vomiting is common. Photophobia is common. Neck pain, neck stiffness is common. So a lot of those patients, at least initially, are diagnosed either with meningitis or they're diagnosed with migraine headaches. And then on the right side, you see a whole bunch of, more rare, uncommon type of disorders. And we'll go into some of those, not all of them, some of those a little bit later. So how do you diagnose SIH? So we keep really close track of people who really have spontaneous intracranial hypotension. Because over the years, as this diagnosis has become more common, there are a lot of people out there who think they have SIH, but they really don't. And as a matter of fact, for every patient I see in my office who has SIH, I see about 3 or 4 or 5 of them who do not have it, but they have somewhat orthostatic features to their headache or other symptoms. So if you go by the International Classification of Headache Disorders, third iteration, their diagnostic criteria, and we worked on that we started it about 10 years ago, I think. And it's really any kind of headache. So the number 2 ICD-HD criteria said it had to be an orthostatic headache, but because it's not always orthostatic, we got rid of that. So it's really any kind of headache, but you have to have some objective evidence for a spinal fluid leak. So either that's a brain MRI that shows the stigmata of a CSF leak, and we'll go over that, what that could be, or it shows a CSF leak on any kind of spinal imaging. So that's under B, where it says evidence of CSF leakage on imaging. Now, of course, this is the international classification of headache disorders, right? We're not talking about the US or Turkey, but also in communities where there is no imaging. So the only way you can confirm the diagnosis then is to do a spinal tap and measure the pressure. And we consider normal opening pressure on a spinal tap in the lateral decubitus position to be between 6 and 25 centimeters of water. So if it's less than 6, then you meet the criteria for SIH. Now, of course, that's a little bit tricky, right? I don't know how many of you still do spinal taps, but sometimes, you think you're right in the right spot, but there can be a little nerve root that's covering the opening of your needle, and you get a erroneously low opening pressure. So that's of the different objective criteria, that's certainly the most subjective. Now, we're all familiar with these MRI findings. What I'd like to point out is that brain sagging, you really can only get from a spinal fluid leak from the spine. And that was first described back in the 70s on a pneumoencephalogram. So even on pneumoencephalograms, you can diagnose that. But I think the reason we see more and more of these patients is because of Dr. Mokri and Dr. Ebersold's work from the Mayo Clinic, who were the first to recognize that when you have a spinal fluid leak, you can get meningeal enhancement. Basically, that means that the veins underneath your dura light up. And the reason for that, because of the Monroe-Kelly doctrine, if you lose spinal fluid, you need to make up that space. And the easiest way to make that up is to dilate the veins. And the subdural zone has a lot of small veins that can dilate, and that causes the meningeal enhancement. So these are sort of the MRI findings, and SEEPS is a mnemonic we came up with some time ago, with S being subdural fluid collections, that's usually acute on chronic subdural hematomas. E is enhancement of the meninges. E is engorgement of veins. P is pituitary hyperemia, or it's really pituitary enlargement. S is sagging of the brain. And R, that's something relatively recent, and with that we mean reduction of the fluid space around the optic nerve. And then these are just some pictures of what it looks like prior to and after treatment. So A and B are the subdural hematomas. The arrow that you can see here points to an infarct. Sometimes people with SIH get cortical venous thrombosis. You can get a venous infarct. E and F are dilation of the superior sagittal sinus. Sometimes that's a little bit hard to recognize on your pre-treatment scan, but it's easily recognizable because of the difference between pre and post-treatment. The lower one on the left is sagging of the brain. We'll go into that a little bit further later on. C and D is the enhancement of the meninges. And as you can see, it's the peckymeninges, right? It's the dura, it's not the leptomeninges. The pituitary enlargement, so here in G, if you look at that pituitary gland, you'd say that's a normal pituitary gland. And then after you treat the patient, you see that she actually has a baseline partially empty sella. So that's her normal pituitary. And the actual abnormal pituitary, which was before we treated the leak, looks relatively normal. And then these last two panels, K and L, is this reduction of the fluid around the optic nerve. So in K, that's before treatment, we call that dry eye. So you can hardly tell that there's an optic nerve, but then after treatment, you get the normal subarachnoid space back, and you can see these little donut-shaped areas around the optic nerve. Now the brain sagging, as you can see on the right side, is very easily distinguishable from a Chiari malformation, right? So when you have brain sagging, you do get downward displacement of the cerebellum, but the pons is totally flat against the clivus. The mesencephalon, the midbrain, is totally distorted. The optic apparatus bows down over the pituitary fossa. There's no subarachnoid space here. It looks very, very dry. And then, let me go back to that. But then when you have a patient with a regular Chiari, you see it's really just the downward displacement of the cerebellar tonsil. And the rest of the brain looks very normal. This is the usual situation. I'd say 19 out of 20 times or even more, it looks like this. But sometimes it really looks just like a Chiari. So this is an MRI scan on the left that shows downward displacement of the cerebellar tonsils. Looks just like a Chiari. There's absolutely no brain sagging. This is what it looked like after we fixed the leak. So you see that the tonsillar herniation is gone. And then this was caused by a ventral dural defect with a spinal fluid leak. So usually it's pretty easy to distinguish it, but not always. Now, I think it's important to realize a few caveats as far as MRI is concerned. So we think about 1 out of 5 patients with a leak have a normal brain MRI. They always have a normal brain MRI. Sometimes what happens, actually what happens more frequently than not, is that with or without treatment, all these abnormalities on the brain MRI, they will just resolve with the passage of time. That can be within a few weeks, can be months or years. And then rarely we've seen some patients who have a totally normal MRI scan in the beginning, but it's not until after a few months that the abnormalities appear on the MRI scan. Now that's how you can recognize a patient most of the time, 80% of the time, just by looking at the MRI scan. Now, what are the risk factors for a spinal fluid leak? There are many risk factors that we've looked at. There's connective tissue disorders that seem to be, really important when we first learned about these disorders. More or less trivial trauma is important. Bone spur seems to be more common in the spring. We found that people who have bariatric surgery, weight loss surgery, are at higher risk. We've had several patients who got it after a spider bite, when they had, probably a lot of proteolytic enzymes in their body. Pre-existing high pressure could be a risk factor. Some patients have these abnormal vascular abnormalities in their body that can suck out the spinal fluid. But we'll just talk about a few of them. So this very first patient that I saw back in 91 was very tall and lanky. She looked kind of morphinoid. She had very obvious joint hypermobility. And when we wrote our manuscript, we also included this picture of her joint hypermobility that you can see here. But the editors of the Journal of Neurosurgery poo-pooed that and said, well, that has nothing to do with it. You have to get rid of the picture. So we never actually published that picture. But we do think that joint hypermobility, generalized connective tissue disorders do play a role. We just really have no idea what role it is, what gene it is, what gene product it is. We did do some studies, but this is already from 20 years ago. We looked at the microfibrils. Microfibrils are specific proteins in your extracellular matrix that maintains the extracellular matrix. And it seemed that particularly these people with morphinoid features had abnormalities of their microfibrils, but we have no idea which component of the microfibril that is. When I looked at it with geneticists here, we actually found that about 1 out of 5 people, it looks like, have some underlying connective tissue disorder. So when you do skin biopsies on these patients, you find some abnormalities on electron microscopy about 20% of the time. About 20% of patients have aortic dilatation. We have found brain aneurysms in about 8% of patients with SIH. So we think that's something also to do with the connective tissues. So whenever you think about connective tissue, you think about genetic, and it probably is genetic, but it's not just genetic. And the reason I say that is because it's really rare to have a family history of SIH. So I think out of the 1,600 plus patients with SIH we've seen over the years, we only have about 5 or 6 families with SIH. Now, even though, again, we see a lot of people from outside of California, we try to be very practical with our approach to SIH. And we like to become more and more non-invasive. So early on, we do not do a lumbar puncture. So when people come into our hospital and they've never been treated, we don't do an LP. We just do an MRI of the brain, and we do this MRI myelogram. With an MRI myelogram, I mean, it's a regular high-quality spine MRI with heavily T2-weighted MRI imaging. We haven't done CT myelograms for about 10, 15 years. And just based on that, we'll go ahead with blood patching. And if we're lucky enough to know exactly where the leak is coming from, we'll do glue without really searching for the site of the leak. Because I think it's important to realize that if you do a high quality spine MRI, it's just as good as a routine CT myelogram. And these are some data from a study we published last year in JAMA Neurology, and it's kind of a busy slide there, but we had 276 patients who had both CT myelograms and MR myelograms, and these were all patients who had a leak, right? And with that, I mean they had spinal fluid outside of the dura, and only 8 out of those 276 patients were diagnosed with only CT myelogram or only MRI myelogram. And if you really look at the data, there were 7 who had it diagnosed with the MRI myelogram, not with the CT myelogram, only 1 where it was reversed. So if anything, looks like MRI myelogram might be a little bit better than CT myelography. In the beginning, when I started seeing these patients, we really didn't have a good idea, what the different reasons were for spinal fluid leaks. But with better imaging, we were able to classify the different type of leaks, which is important because it not only helps your decision-making as far as how you should treat the leak, but it also can give you some important information as far as success of treatment and possible long-term ramifications. Now, in the olden days, and still in a lot of other medical centers, a lot of attention is paid to whether or not somebody has CSF rhinorrhea. So I think it's really important to realize if you have CSF rhinorrhea or otorrhea, that does not cause SIH. That's never been described. So when we wrote this article a while back, we said that skull-based CSF leaks do not cause SIH. But of course, there's always an exception to the rule, because last year we saw this 13-year-old boy who clearly had SIH. He had orthostatic headaches. He had a tremendous amount of brain sagging, as you can see in panel B there. And he actually had a skull-based CSF leak. So he was leaking from the posterior fossa through the porus acousticus into the soft tissues of the neck and into eventually the subclavian vein. I know there's another teenager in Europe who has exactly the same thing. So it's not like a unique case, but it's a really, really rare case. So just to give you an example, it's only like 1 out of over 1,600 patients we've seen with SIH, but it shows you that rarely you can have a skull-based CSF leak causing SIH. And I think this was such a tremendous fast leak, as you can see on these digital myelograms at the bottom of the screen, that it was really just sucking out the spinal fluid from the spinal column. So indirectly, it really was a spinal CSF leak. So this is the classification of CSF leaks of the spine that we came up with. It's either a ventral leak in front of the spine, lateral on the side. It's associated with a simple cyst. It's associated with a complex cyst, or also called Duralactasia, or it's what we call a CSF Venus Fistula. And we'll go over those in a little bit more detail. So what I call type 1 leaks are the typical leaks, how you would explain it to a patient. So it's a tear in the dura. It is either 1A in front of the dura or 1B on the side or in the back of the dura. Or it's associated with a cyst, type 2, a simple cyst, 2A, or Duralactasia, 2B, or it's type 3, which is this more recently discovered type of leak, the CSF Venus Fistula. That's a type of leak that exists without any evidence for extradural CSF. And then type 4 leaks are indeterminate leaks. That means that we don't know what the cause is. And that either means that it's a patient who comes to our ER, they have an abnormal brain MRI, they have extradural CSF on their spine MRI, we do a blood patch, they're cured, we never see them again. We don't need to know what the cause is of their leak. Or it's somebody with SAH, and in spite of all of our investigations, we just never know what the cause is. So this is what this typical type 1A or ventral leaks look like. That's usually associated with a piece of bone, as you can see here on this axial CT scan. So here there's a piece of bone that has punctured the dura that has caused the leak. At surgery with ultrasound, here it's the spinal cord, and then this is the calcified disc. And then at surgery, looking from the back, right? So this is an intradural approach, posterior intradural approach. This is the spinal cord. You see the tear here, like this oval shaped opening in the ventral dura with this sharp little osteophyte that has punctured the dura. Like I said, usually that's associated with a little microspur or osteophyte, almost always that's the case. Typically, the dural tear is pretty small. So even though the leak might be tremendous and might look very bad looking, right? It extends all the way from the neck to the tailbone. The tear is usually only about 4 or 5 millimeters in length. So it's pretty small. Usually it's in the thoracic spine, not always. If these leaks have been there for more than a couple of months, they always require surgery, at least in our hands. There's a high risk of developing superficial siderosis if you leave these leaks untreated. So the osteophyte can be very variable. It can be very tiny, as you can see here. It's just like a punctate little piece of bone, or it can be, looking like this, where it takes up most of the spinal canal. The dural tear, like I said, is usually pretty small, but it can be really tiny, as you can see here. You can hardly see it. You kind of have to magnify it. So that's a tiny little opening, only 2 millimeters. Or it can be really easily found when you do surgery. And then I'd like to talk a little bit about this superficial siderosis. So these are some really good review articles that came out recently. Superficial siderosis, what we call typical or infratentorial superficial siderosis, presents with ataxia, hearing loss, and myelopathy. And the focus, the center of the superficial siderosis, and again, it's hemosiderin deposits in the subpial regions of or subpial layers of the brain and spinal cord. The center is in the superior cerebellum, and it's not caused by a ruptured aneurysm or a head injury. It's caused by chronic bleeding into the subarachnoid space. And actually, spinal fluid leaks are the most common reason for superficial siderosis. And a year ago or so, we published this article looking what is the risk if you have a ventral leak, a type 1A leak, that is not cured. And if you follow those patients over the years, so after you follow them more than 10 or 15 years, the risk of superficial siderosis becomes pretty high. It's about 50% or so. So treating those leaks before they develop superficial siderosis kind of gives you a unique opportunity to potentially prevent a pretty devastating neurologic disease from happening. Now, this study had a relatively small number of patients. So if you look at the 95% confidence intervals, they're pretty high. So the risk at 15 years could maybe only be 20%, but it also could be as high as 80%. It's really not known. Now, where do those people bleed from who have ventral leaks? They bleed from the epidural plexus. So again, this is looking from the back, intradural approach. And then through the dural tear, you can see this dilated blood vessel. And you can see it's very easy for those to have chronic bleeding, also because there's a little sharp piece of bone that could injure the vessel. And because of this constant washing out of spinal fluid, it's difficult for the vein to thrombose. This is what this typically looks like, superficial siderosis. So here on the SWI imaging, you see all this black hemosiderin, the superior cerebellum. This is a large collection in front of the spinal cord of extradural CSF. This is what it looks like under the microscope with surgery. This is the tear. You can see all this hemosiderin in the arachnoid and covering the spinal cord. And after suturing, you see that that ventral collection is completely gone, in this case within 48 hours. Now, this is another long-term complication of a ventral leak. It's called Bibrachial Amyotrophy. And it's really a more or less severe weakness and loss of muscle, mainly of the upper extremities. And it can look like amyotrophic lateral sclerosis. And this is what this looks like. This is a gentleman from the Middle East who's had this for many years. And you can see he's pretty debilitated with that. The young guy can't really move his arms. And then this is a lady who had really the most severe form of that I've ever seen.
Can you move your arms at all?
Well, I can move my body.
So you can tell, it's tremendous atrophy, and she really has no power in her muscles at all. The only thing she could do was just move her thumb a tiny little bit. Now, what I call type 1B leaks are the leaks that are on the side of the spinal cord. This is what that looks like on CT. So it's on the side of the spinal cord. And at surgery, we used to think that this was like a ruptured cyst or a ruptured diverticulum. That's really not the case. It's a tear, a lateral tear, usually starting at the axilla of the nerve root, where the nerve root sleeve is. And then through that tear, you see the arachnoid billowing through, and that looks like an arachnoid cyst. But the primary pathology is the dural tear. So those do not have an associated microspur. Those might be the patients who have a microfibrillopathy, also usually thoracic. You can treat those with glue really well at any time. So even if you have a patient who's had this for many, many years, you don't need to rush into surgery. You can just use glue first. And there's really none or very little risk of superficial siderosis. So again, these are the patients who probably at higher risk of having an underlying connective tissue disorder. Also, those patients on average are younger than other patients with leaks. There's less risk of superficial siderosis. Now, why is that? Those patients also have a very extensive extradural CSF collection. And I think the reason of these lateral leaks being at lower risk of superficial siderosis is that they're not in contact with this very extensive epidural venous plexus that's in front of the spinal cord. And also, so unlike the ventral leak that you can see here, the lateral leak usually is covered by a connective tissue membrane. So it's really not in touch even with any sort of blood vessel. So I think that's why those leaks do not develop superficial siderosis. And then this is what you typically see in somebody with SIH. It's a whole bunch of different meningeal diverticula. But you have to be careful of saying it's caused by that because it's actually very common. So Peter Kranz from Duke a couple of years ago wrote this paper where even though it's more common in people with leaks, you can clearly see that about 20–40% of patients, 20 or 40% of the general population has one or two of these meningeal diverticula. So that by itself does not mean that you have a spinal fluid leak. Now these leaks leaks associated with meningeal diverticula rarely have a large amount of extradural CSF. So this was an unusual patient who was diagnosed with hydrothorax about 15 years ago, and they did a pleurocentesis, and they checked it for beta-2 transferrin, and it turned out to be spinal fluid. She had a lot of glue and blood patches done, so she ended up needing surgery, where I just clipped this cyst. This cyst here was the one that was leaking spinal fluid into her pleural space. And then type 2B are the complex type of meningeal diverticula, or Duralactasia. And Duralactasia is oftentimes associated with an underlying connective tissue disorder. And it can be something that's not genetic per se, like ankylosing spondylitis or Bechtereau's disease, even though it's associated with HLA-B27. It's not something you get from your parents per se. So here you see the Duralactasia there. That looks fairly mild. In Marfan syndrome, the Duralactasia is much more severe. It usually involves the sacrum, as you can see here. And then also neurofibromatosis type 1 can have really severe Duralactasia that you can see here. This one on the left is a 43-year-old lady. This one here in the middle is very extensive lumbosacral Duralactasia. This is a teenager. And then this is very extensive thoracic Duralactasia in NF1 in a gentleman in his 50s. And then type 3 leaks, or Csf Venus Fistulas, are really, have made a tremendous difference once that was discovered, because it involves probably a lot of patients. Probably 1 out of 3, 1 out of 4 patients with SIH turn out to have these Csf Venus Fistulas. So that's a situation where, as you can see here, this is during surgery. Here you can see the common thecal sac. This is a little cyst, and then attached to the little cyst, you see this vein, and that's a normally appearing vein, right? Everybody has small veins along the nerve root sleeve that absorb maybe 2–3% of your spinal fluid. But if it happens to be attached to one of these little meningeal diverticula, there's oftentimes a little arachnoid granulation, and then at some point that can rupture into the vein, and that can cause a tremendous amount of leaking of spinal fluid into the epidural spine. So again, that's what we think is a ruptured arachnoid granulation. We discovered that here about 9 years ago exactly. Usually it's associated with cysts or meningeal diverticula. These are the type of leaks that are associated with vascular malformations, also most commonly in the spine. And we still don't really know how common it is, because it's only been known for about 9 years or so. Sometimes it's a little bit hard to detect them on a scan. This is one of these digital subtraction myelograms. Here you can see the cyst, that's pretty obvious. And then here you can see the vein that's attached to it. That's pretty, pretty subtle. Here you can see it from the side. It's not that common, or it's not that obvious. But it's not always like that. So sometimes it's really obvious, like this is a cyst, and then there's a tremendous amount of contrast going into the veins here in the foramen, and then along the vertebral body going up and down. Usually it's from the cyst, but not always. So sometimes it can also just be from the common thecal sac. So the most common scenario is where the vein is attached to the cyst, as you can see here. Sometimes it's attached from the nerve root sleeve, but not the cyst itself. And then, as you can see here, the Csf Venus Fistula is attached to the common thecal sac, and it's not attached to the cyst that's behind this little retractor here. And even though most of them are in the thoracic spine, we've also seen them in the cervical spine, and the lumbar spine, and even in the sacrum. This is a patient who was airlifted here this summer from New York. She was 17. She was born with this venous vascular malformation that you can see here, and she developed tremendous orthostatic headaches. This is her MRI scan. You can see the Chiari-like cerebellar tonsillar herniation. Here you see that there's not enough spinal fluid. Pontomedullary distance is very tiny. It's less than 2 millimeters. And then here is part, obviously this is her thecal sac. Here's part of this vascular malformation that extends throughout her pelvis. Here you can see that again. And then when we did the digital myelogram, you see that out of this small sacral cyst, there's this network of fistulas, and then it collects into the vascular malformation. Now, we had a really difficult time treating that. Dr. Maya went through the venous system, tried to embolize it transvenously with onyx, wasn't able to. I tried to do surgery, but there was a tremendous amount of blood loss. We had to abort the surgery. So finally, Dr. Maya was able to cure it with placing onyx through the foramen directly into the fistula and the vascular malformation. And right now she's doing great. She's back in school. She's partying with her friends. No more headaches. She actually has a little bit of a rebound high pressure headache now. And you can see that her brain has floated back up again. Now, we look for the CSF venous fistulas all the time. We do 3-4 DSMs every day. And if you have a patient with a positive brain MRI, right? So if you have an MRI scan that shows these typical stigmata, but there's no extradural CSF, right? So it's in that half of the population with SIH that does not have extradural CSF. We are able to find the fistulas about 80, 90% of the time. Now, if you have a normal brain MRI, but you have a patient with orthostatic headaches that gets better with epidural blood patching, but a totally normal brain MRI, we find it about 10% of the time. It's 0% of the time if there are no meningeal diverticula, and it's about 20% of the time if we do find meningeal diverticula. Then there's another clinical problem that's called behavioral variant frontotemporal dementia, and I'll show you a small segment of that. But if you have that, that's always associated with a tremendous amount of brain sagging. For whatever reason, we're only half as good as in other patients in finding these fistulas, and we haven't really figured out why that is. So it's not just the imaging of the brain, it's not just the imaging of the spine, but it's also the clinical scenario, the clinical presentation that allows you to prognosticate how successful you are in identifying CSF venous fistulas. This is somebody with behavioral variant frontotemporal dementia that can occur in the 30s, 40s, 50s. It's a very common type of dementia prior to age 65. It's people who have tremendous personality abnormalities, problems with behavior. So this was a young guy in his 40s who was like this. So he would like sit down naked at home. His wife videotaped him, and he would like have zero initiative, like nothing. We'd just sit there. And she tells me he would do that for 2-3 hours at a time. I will not show you 2 or 3 hours of this video, but so that's what it was before treatment. And then this is what it looks like after treatment.
I felt better after my surgery, and I'm doing really good.
So, as you can imagine, if you ever see somebody like this is like a terrible, terrible disease. And just with a simple procedure to fix a fistula, you can really make a tremendous difference in somebody's life. Now, again, we try to be, very practical in our approach, not only with imaging, right, but also with treatment. So we get the MRIs, and then unless somebody already has had prior treatment, which obviously is most of our patients, but not everybody, we do epidural blood patching, right? You don't need to know where the leak is coming from to do epidural blood patching. And it seems to be curative for most patients with SIH. This is from a recent meta-analysis by Dr. Mataru and his group. And you can see on this figure here that, whether you do targeted, non-targeted, small or large, you can cure, the majority of patients with SIH just by doing blood patching. Now, this, of course, is a neurosurgery meeting. So for the rest of the presentation, I'll try to mostly talk about surgery. So surgery is very, very satisfying, right? Mostly because patients do really well. The radiology nowadays is so good that we almost always know exactly where the leak is coming from. And in spite of, doing surgery on ruptured aneurysms, the stress level is a lot less. And of course, the morbidity is a lot less. So we're very heavily weighted towards surgery. There's a tremendous referral bias. So when I looked at this a couple of years ago, about 50% of patients who we saw here at Cedars underwent surgery. But if you look in the community of Beverly Hills that we talked about a little bit ago, so that's right next door to Cedars, only about 10% of people need surgery. So I think, especially for us neurosurgeons, it's important to realize, especially once you build a practice, that you really need to have good colleagues who can treat these patients without surgery, with percutaneous measures. And for me, when I was a resident in the 90s, it was just about learning about CSF leaks. The only surgery we did is we would sometimes clip the cyst, and then we did a lot of exploratory surgery with packing of the epidural space, the lateral gutter. Then when I started here at Cedars, we established a CSF leak center. Surgery wasn't that different from when I was a resident. And the tremendous difference is when we started doing digital myelography, which allowed us to classify the leak and localize the leak. And that's made a tremendous difference in my practice. So this is sort of how we treat patients, right? So in the beginning, we do some conservative measures, usually not too much, maybe 24, 48 hours. We have a very low threshold to do epidural blood patching. Again, you don't need to know where the leak is coming from. But then if that fails, right, and we've done blood patches that have been successful with as little as 5 cc's of blood or as much as 135 cc's of blood. For blood patching, we don't have a predetermined volume. We just keep giving it until, the pressure builds up, people get some pressure in their back or sciatica type of pain, but we don't have a predetermined volume. But if that doesn't work and you want to do fibrin sealant, if you want to do glue procedures, and Dr. Maya and Dr. Moser are the first ones to ever do that back in 2003 for spontaneous leaks, or of course for surgery, you need to know where the leak is coming from. You need to have a target. And this is sort of our approach as far as imaging is concerned. So again, we start with the MRI scans. We start with blood patching. But if that is not enough, we look at what does the spine imaging look like. If there's extradural CSF, that's called spinal longitudinal extradural collection here. And the collection is in front of the spinal cord. We do a prone digital myelogram. Right, because of gravity, the contrast collects in the ventral aspect of the subarachnoid space. So if it's a ventral leak or we suspect a ventral leak, we do a prone myelogram. If it looks like it's a lateral leak based on the MRI, we do a lateral decubitus DSM. If a patient does not have any extradural CSF, then we do a lateral decubitus DSM. Now, of course, you can have CSF Venus Fistulas on the left side or the right side. So we usually do 2 of them. About 10% of patients have multiple CSF Venus Fistulas. So if we find it on one side, there's a less than 5% chance that there's another one on the other side. So some patients will want to know, other patients will say, I'll just treat the one. If that's successful, great. If it's not, if I'm in that less than 5%, then I'll have you look on the other side. This is what these digital myelograms look like. This is for somebody with a ventral leak. So the dye is coming in from the bottom. It's at a speed of about 2 frames per second. And there you can see how the dye leaks out, you know exactly where it is. And then it extends both in the intradural compartment and in the ventral extradural compartment. This is an example of a Csf Venus Fistula. So these are lateral decubitus DSMs. So here you see the meningeal diverticulum and then this network of the venous drainage. And this is another one. Now, of course, you don't need to use DSM, right? Digital subtraction myelography, even though you're either endovascular neurosurgeon or your interventional neuroradiologist, has the equipment. It's the same equipment as a digital subtraction angiogram. But instead of injecting it intravascularly, you inject it intradurally. So for the ventral leaks, I think if you've only had it for a few weeks or months, even if there's a big pony spur, you can cure it just with epidural blood patching. If it's somewhere between, let's say, a couple of months and half a year, you can try to do directed treatment. So you can go transforaminal, put your needle ventral to the cord, especially if there's a big collection of CSF that makes it safe to do it. And then you can inject your glue or your fibrin sealant. But if that leak has been there for more than 3 or 6 months, we don't try to fix it percutaneously. We go directly to surgery. Now, of course, we use a DSM. Other people use dynamic CT myelography. That's also a really good way of looking at it. Some people from Japan have reported good results of doing high resolution MRI, where you can actually see the dural hole on an axial MRI scan. We have not been very successful with that. And sometimes you cannot find it with any of those modalities. And then I sometimes just explore where I think the leak is coming from based on the most worrisome looking bony spicule. Sometimes it's really easy to find the leak, right? Particularly if it's in the lower thoracic spine. But a lot of them are in the upper thoracic spine, where because of the shoulders, it's more difficult for the x-rays to penetrate. So sometimes it's more subtle and you really have to look at it, with some of your colleagues. We've known since the last century that these can be caused by a bone spur. This is what this looks like. It's oftentimes like a little scalpel like this. Sometimes it's more like a typical looking little calcified disc herniation. Again, these bony spicules are there most of the time. Sometimes people have multiple ones. It's not always the largest, as you can see here. So this spicule that you see on the left, I thought that's where the leak was coming from, but it actually turns out to be this tiny little dot of calcium. That's where the leak was coming from. So you easily can be fooled just by looking at the configuration of the microspur. And then we've had a few patients where the CT myelogram that was done on the outside clearly showed a little bony spicule, as you can see here and here. But then with the passage of time, these spicules absorb. And I do think that the spicule that's associated with the leak is at higher risk of absorbing just because of the constant flow of spinal fluid. Like I said before, I use a posterior intradural approach. Once we started doing digital subtraction myelography, I first did an extradural approach just because I thought intradural approach was associated with too high of a risk. but the results of extradural approach, at least in my hands, was not very good. 50% of people still had a leak. Sometimes their symptoms were gone, but when you did an MRI, they still had an extradural CSF collection. So since the summer of 2011, I've only done intradural approaches, at least for the thoracic and lumbar spine. For cervical spine leaks, I still use an anterior approach most of the time. So these are just some pictures. I like to take pictures of these dural holes. They all look, pretty similar. And then why do I take pictures? It's because it confirms to the patient that indeed they had a leak, right? So patients like looking at it. They like to put it on their, Facebook page or their Instagram. Also, you learn from it because, later on you can kind of study the anatomy. It's an easy way to measure it because I usually take a little picture with a rodent 10. That's a little tiny micro instrument. Also, as you, for example, can see here, you can see that there's a tear here, but when you look carefully, this looks like thick dura, and then this is really all scarred in dura. So the original tear was much, much larger than the hole that was still present when I did the surgery. They all look very, very similar. I've done about 300 of these surgeries. Also, the associated herniated disc, it's very easy most of the time to just resect that. So here you see the disc material, you sort of morselize it with a micro instrument, you remove it, and then you can suture the dura afterwards. Now, sometimes, at least in my hands, it's not that easy or safe to suture the dura. So for many, many years now, I have not done a lot of suturing, and I just use a muscle graft. So as you can see here, this dural opening is very much to the midline, and maneuvering your needle there and suturing really puts the spinal cord at risk. So then what I use is a little muscle graft. I just get that from the paraspinal muscle. You put it through the defects, or like in an hourglass configuration. So some of it is extradural, some of it is intradural. I put 1 or 2 drops of fibrin sealant there, and the results of that are just as good as suturing. So I usually do a full laminectomy, sometimes a hemilaminectomy. I tend to resect the medial third of the pedicle. I make a midline or paramedian incision. I divide the dentate ligament. You find the tear. I always use intraoperative monitoring, even though nowadays it's so sensitive that you can get, almost absent motor evoked potentials, even though the patient wakes up fine. But I still like doing it. The amount of bony opening, you can really minimize that. And this is from a paper that came out last year, a group from France, where they really make a very, very small opening to do the ventral CSF leak repair. This is what we usually do after a hemilaminectomy. But sometimes I like doing a full laminectomy because I think actually that I do that most of the time, because I think it's a little bit safer. If you don't get a good look from one side of the spinal cord, you can look on the other side. Then for ventral leaks, I don't do a discectomy that doesn't give enough space. I do a corpectomy. Actually, one of my colleagues, Dr. Ray Chu, does the corpectomy. As you can see here, this is a patient. They had to try to fix the ventral tear many years ago, developed superficial siderosis, and put this plate on. So with this, I did not want to go ventral, and I actually did a posterior approach. As you can see here, that's the little opening that's still there. Now, what's the success rate of surgery for ventral tears? The radiographic success rate of surgery is really high. So you really have to kind of scratch your head and see what went wrong when you operate on somebody and they still have a leak afterwards. It can be because one of the sutures tore through, or the muscle plagiate might not have been big enough. Very rarely people have more than one leak, super rarely. really the main risk is causing a leak. So about 4% of people I operate on, they end up with a pseudomeningocele. I think sometimes what happens is when you close the dura, afterwards, the pressure builds up because the original leak is gone, and they can start leaking through the suture line. Neurological deficits that I've encountered have all been transient. It's mostly with people who've had prior intradural surgery because there's some, intradural scarring. But in spite of complete radiographic resolution of the leak, you still have about 10–15% of patients who have persistent symptoms. And that's always a little bit difficult to deal with, especially as a neurosurgeon, because you can't really fix their leak anymore. So then it usually becomes more of an issue for the headache specialist. This is what you like to see, right? Patients send you nice pictures of what they're able to do after surgery, but it's not always like that, right? So sometimes the leak is gone again, but they're still having symptoms. And then there are some postoperative complications that I'd really never seen before. So I thought I'd share that with you in case you come across that. So this is a gentleman I operated on. He had a typical ventral tear. You can see there was just a tiny little piece of bone there. This is what it looked like before surgery. I operated on him, removed just a tiny little piece of bone, like a little grain of sand almost. And about 6 months later, he called me that he was having some numbness in his legs. And we had him go get an emergency MRI scan. And I got a call from the radiologist, the gentleman lives up in San Francisco area. And he has this calcified disc herniation. This is about 6 months after surgery. So that's unusual. I think it might have been precipitated by me removing the little piece of herniated disc. But if it is related, and obviously I think it's related, it's something that's very rare. I've never seen it since. Another kind of scary thing, if you look at it on a scan, this is just a routine post-op MRI scan. And you see, this is at the level of the upper lumbar spine. You see that the cauda equina is totally compressed by these two CSF collections, one ventral, one posterior. Those are not spinal fluid leaks. I think sometimes what happens when you find the tear, there can be fluid that goes between the arachnoid and the dura, and you get these collections where the arachnoid sort of has sheared off the dura itself. Don't operate on it. It will just resolve on its own. I've seen this about 2 or 3 times. And then this is one of the very earliest patients I've operated on, who, even though it caused no symptoms, had a tremendous amount of adhesive arachnoiditis. And I'm not sure what the reason is. Maybe I used a little bit too much glue there at the time. I'm not sure. But again, nowadays I only use like 1 or 2 drops, and it hasn't really, or it has not happened since. Now for the lateral leaks, again, that's a leak that even if it's been going on for years, you should consider glue. And for that, it's an extradural approach. I haven't seen any neurological deficits from that. I've had a few patients who developed a pseudomeningocele from where the surgery was performed, a little bit higher than ventral leaks. Again, this is what that looks like. This is a myelogram done somewhere else. Here you can see the arachnoid coming out of the dura with spinal fluid around it. And that's what that looks like at surgery. So again, it's not just a cyst that's leaking. There's a tear that you can see here that needs to be repaired. And I usually use aneurysm clips, but you also can just suture it. And again, a lot of these patients have these membranes around it. So you really have to open the membrane when you do the surgery in order to find the dural tear. So when you do the surgery and you do your foraminotomy, don't think like, oh, this is the cyst and try to fix it. You have to open that membrane around the tear. Now, these are the simple diverticula. Usually I just clip that. These are the complex diverticula. Those can be really kind of problematic to deal with surgery. If you're not able to close the dura, like you see a picture of that here, right? A lot of the time, the sacral dural ectasia, the dura is gone by the time you drill off the bone. Sometimes I've had to do surgery with a plastic surgeon who will get a muscle flap and put that into the cavity within the sacrum. But what I think when you talk to neurosurgeons, I like to say when you compare simple to complex meningeal diverticula, it really is all about the surgery. So the complex diverticula are at high risk of these pseudomeningocele. So, I mean, obviously, some of these patients need surgery to fix the leak, but I definitely have a bit of a higher threshold when you have duralactasia. And then for the CSF Venus Fistulas, I think pretty much everybody who's dealt with those, we're all of the opinion that epidural blood patching is less effective. Why that is, you can sort of visualize that if you have a tear in the dura, the blood can find its way there and cause some inflammation and seals the dural defect. But with a CSF venous fistula, it's probably not the case, right? Maybe if the blood gets there, it can compress the fistula a little bit, but you probably need, more aggressive treatment. And there are really three options. One is glue injections, one is endovascular paraspinal vein glue embolization, or it's surgery. So in the beginning, when we discovered those in 2012, the first 12 or so, we did fibrin glue injection. That hardly ever helped. So then we went to surgery. But nowadays, when we do it, I think we're able to cure about 70–80% of CSF venous fistulas. We do this under local monitored anesthesia care. It's an outpatient procedure. And this is before surgery and after surgery, or after glue injection. And you can see it's really the most elegant because you can't even tell somebody was here, right? Because the fibrin glue, the tissue sealant we use, dissolves after a few weeks. Now, in 2020, the group from the Mayo Clinic started doing endovascular glue embolization. So that's where you inject onyx, a different type of glue. It's more of a hard plastic, through the paraspinal veins. And we started doing that last year. That seems to help maybe about 80% of the time. We don't have enough cases yet to say that, but that seems to be the experience from the Mayo Clinic. It's an outpatient procedure. We do it under general anesthesia. And then you have to weigh that against, surgery. So with surgery, it's obviously general anesthesia. It's usually one night in the hospital. But the cure rate is really, really high. So, it really should be better than 99%. There's no reason why surgical ligation of the fistula would not work. But it is surgery. So if you find the actual fistula, it's always important to look for it. You can just clip or cauterize the fistula. You don't have to worry about the nerve root. If the fistulization is more distal along the nerve root, and that's the case most of the time, if it's a non-eloquent nerve root, so most thoracic nerve roots, you can also clip that nerve root sleeve. And I like to use aneurysm clips because I think it's enough clipping to prevent the fistula, but it's not doesn't ligate the nerve root. Some other people actually ligate and cut the nerve root. I don't think that that's necessary. I think clipping works at least as well and is less traumatic. These are just different pictures of the CSF venous fistulas. So here you see a little diverticulum with the vein coming out. Same here, a little diverticulum, vein coming out. These are just different examples of that. We already went over that. I think if it's a CSF venous fistula and it's coming off an eloquent nerve root, then even fibrin glue percutaneous injection has some risk of damaging the nerve root. So if at all possible, We do endovascular paraspinal onyx embolization if it comes from an eloquent nerve root. This is from a patient before we did paraspinal vein embolization. So this, I think, was the L3 nerve root. I had to do a facetectomy, you have to do a fusion. It becomes much more involved of an operation. And then sometimes you sort of have to do a combination, right? So like I said at the beginning of my presentation, it's really important to have good colleagues. It's helpful if they're nice people to work with, like I have the privilege of. So this is somebody who has Gorham-Stout disease, vanishing bone disease, who keeps having recurrent Csf Venus Fistulas. And the only way we could cure it was by clipping. We did percutaneous glue, we did endovascular onyx, and then we did percutaneous onyx. So sometimes you really need many different procedures to treat these leaks. But again, this is a very rare example of that. All right, that's been a lot of talking. Thank you very much for your attention.
Thank you very much for excellent presentation. There are some questions and thanks. Before starting discussion part, I would like to ask you a question. Maybe it escaped my attention during the presentation. Do you have any patients with clinical and radiological findings of SIH, but the location or level of defect cannot be found? How is your approach to these patients?
Yes, so we do have some of those patients. Overall, we're able to detect the leak about 85–90% of the time, but 10–15% of the time we cannot. So you can always do blood patches, but if that doesn't work, and we think it's a fistula, right? So if we think it's a Csf Venus Fistula, it's usually associated with a cyst, then we would do fibrin glue injections where we think the most irregular cyst is. We have done endovascular onyx where we think the most irregular cyst is, which would have the highest likelihood of having a fistula. Or I've done surgery for a cyst like that. So before we discovered the Csf Venus Fistulas, I did a lot of those surgeries, right? So I would do like maybe 3, 4, 5, 6 foraminotomies, just fixing all these different cysts along the spine. And I still do that if, in spite of our imaging, we're not able to identify the site of the fistula. Now, if we think it's a ventral leak, then I will sometimes explore the area where we see an osteophyte or microspur that I think is a likely candidate. And then sometimes the patient is lucky and I'm lucky and it's there. And sometimes I'm not lucky and it's not there. There are a rare group of patients where we know they have a leak, especially if they have like a devastating complication like this frontotemporal dementia and nothing else works. Sometimes I've done what I call dural reduction surgery, where I remove a segment of the lumbar dura, then I suture it back up, and it kind of makes your lumbar dura more of an hourglass type of shape. And then we've also implanted epidural catheters that I then attach to a little portacath that you can place subcutaneously on a rib. And then the patient can access that portacath, him or herself, and infuse themselves with preservative-free normal saline in the epidural space. That usually works really well, right? Because you refloat the brain, but it's very, very cumbersome because it's large amounts of fluid, right? It's not like a morphine pump where you have a pump underneath the skin. This has to be addressed from the outside. So as you can imagine, that means a lot of trips to the doctor or the nurse or having your spouse do it. And there's a high risk of infection and a high risk of inadvertently one day with your needle, rather than going into the port, you actually go into the tubing. So most of those patients after a year have had revision surgery. So I really only use that if somebody has devastating symptoms from their leak and we cannot find the source of the leak.
Thank you very much. One question from Pakistan, Mumbai. Arshad Parek says that how
yeah, Mumbai is in India, not Pakistan.
oh, sorry, Pakistan, from Pakistan.
No, India, from India.
Yes, India. Okay, sorry. Again that. Arshad Parek, how do you differentiate chronic subdural hematoma due to high intracranial pressure or low pressure subdural hematomas?
I think you asked me, how do I differentiate subdural hematomas caused by low pressure? Is that right?
I think so, but
I think so.
maybe he can write his question more clearly.
No. I think I got it. So, you know, as neurosurgeons, we see a lot of patients with subdural hematomas, and I think if it's not from clear trauma, you should have a pretty high index of suspicion of an underlying spinal fluid leak. So, how do you determine whether or not that's the case, right? So, you first look at the brain MRI. If there's meningeal enhancement, you have to look at the posterior fossa. So a lot of patients with subdural hematomas will have meningeal enhancement where you have the subdural hematoma. So that doesn't count anymore as a criterion. But if you have meningeal enhancement in the posterior fossa, that would indicate that there's a underlying leak. If there's brain sagging that's out of proportion to the thickness of the subdural hematoma, that indicates that there's an underlying spinal fluid leak. Most of the subdural hematomas from spontaneous leaks are bilateral, not always, but most of the time. And then, of course, you can image the spine, right? Now, you know, your neuroradiologist might say, well, I don't want to do a CT myelogram. There are subdurals, don't want to do spinal tap. And again, you don't need to do spinal tap because you can do this MRI myelogram and non-invasively look for a spinal fluid leak. And then, of course, history, right? So if you have a patient who says, oh, you know, I started with these orthostatic headaches a month ago, and they come in through your ER with bilateral subdurals, that is a leak until proven otherwise.
Thank you, sir. Beyza Karagöz Güzey says that, thank you for your excellent presentation. Can syringomyelia be associated in these patients due to brain sagging and tonsillar herniation? Did you see such cases? Or else, can we say that a case with syringomyelia is not a SIH patient and she must have Chiari malformation?
Yeah, look, for some reason, I think it's the chronicity of the brain sagging. Patients with a Chiari malformation are much more likely to have syringomyelia than patients with brain sagging. Having said that, I've had dozens of patients with syringomyelia from brain sagging, but it's definitely more common in Chiari malformation. And most of the time, it's pretty easy to differentiate Chiari malformation from brain sagging because you just have to look at all the other factors that cause brain sagging or cause brain sagging that signify brain sagging.
Thank you, sir. Dr. Deniz Belen says that, thank you very much for your great talk. How often do you see SIH patients without any leak? MRI can be normal in the hyperacute phase, and patients get benefit from bed rest and other medical treatment. Do you encounter orthostatic presyncope symptom associated with SIH?
Yeah, well, you know, we don't see that many people who get better just with bed rest because those patients generally are not referred to us, right? The way that we deal with patients with orthostatic headaches, but normal imaging, we usually give them what's called an abdominal binder, which is where you put a corset right around your abdomen, put it on pretty tight. If they feel a lot better with it, we'll offer blood patches. If people have cysts on their spine and they're better with blood patching, then we'll offer digital subtraction myelography to look for a fistula. But a lot of patients with orthostatic headaches and normal imaging do not have an underlying spinal fluid leak.
Thank you, sir. Thanks from Tokyo, Takashi. Thank you for very informative lecture. From Libya, Mane Al-Gaddafi says that thank you for wonderful presentation. Dr. Nurullah Kösmede from our clinic. Thank you, Professor. It was amazing lecture. One question. Panos Sideras says that thank you for the great lecture. Can you please show again the algorithm for diagnosis of leaks?
Yeah. Let's see. This one?
I think so.
Now, I have to go to the operating room. It's 9:30 here. Thank you all very much for listening and tuning in. It's been a real honor and privilege. And I'm looking forward to your next, when is your next presentation? Next week?
No, on Thursday.
On Thursday.
Yeah.
I'm looking forward to the one on Thursday. Thank you very much, everybody.
Thank you very much. And there are some other questions, I think.
Yes. Edwin was from Bulgaria.
Do you want to email me the questions?
Sorry?
Would you mind emailing me the questions and I'll answer them?
Would you like to read yourself or emailing to you?
It's just, I have to go to the operating room.
Okay, okay.
They're waiting for me.
We will send you the questions. Okay.
All right.
Thank you very
Thanks,
much.
everybody.
Thank you very much, sir. Hope to see you again in face-to-face.
Me too.
Thank you.
Thank you.
Bye. I want to thank everyone who joining our conference today, and I will say goodbye. Bye bye.